Regional Chamber. And I'm so pleased to see you here with us this afternoon. Welcome to our expert panel COVID-19 meeting with the doctors. This is being presented by our Waterbury Regional Chamber Healthcare Council. And today we have doctors from 3 of our region's terrific hospitals. Dr. Bieluch of MidState Medical Center and the Hospital of Central Connecticut, Dr. Justin Lundbye of Waterbury Hospital, and Dr. Michael Sims of St. Mary's Hospital. We thank each of them for joining us. And we're going to begin today by having each one of our experts introduce themselves and give a little bit of background as to their roles. And then we will open it up for questions that Dave Krzyzewski from our Waterbury Regional Chamber will be moderating. I'm going to start with Dr. Virginia Bieluch of MidState Medical Center. Doctor, thank you for being here.
Good afternoon. It's a pleasure to be here. I'm Dr. Virginia Bieluch. I am Chief of Infectious Diseases at the Hospital of Central Connecticut and MidState Medical Center. I have a little bit of experience with infectious diseases. I started my career at a time when HIV had just been discovered and we didn't know what was causing this serious infection and people were dying. I then lived through SARS-1 in 2002, H1N1 pandemic in 2009. We had concerns about MERS in 2012. And so I've had a little bit of experience. And as an infectious disease doctor, I've been concerned about a pandemic for a long time. We all have, many of us ID doctors love to travel, and we realized that a virus is only one plane ride away from its area of origin. So in December, we started to hear about a lot of cases of pneumonia coming out of Wuhan, China. And at the end of December, the Chinese declared that they had this epidemic of viral pneumonia. We watched as the virus spread from China to countries in Europe, and we realized at that time that the virus was probably on its way to the United States. So in February, the Hospital of Central Connecticut and MidState Medical Center began planning for how we would handle this surge of patients. We converted certain areas of the hospital into ICU units. We redeployed workers to areas of need. We put a tremendous amount of resources into testing outpatients. And I'm very proud of the dedication, professionalism of all our staff. And that's not only the doctors and the nurses, but everybody who worked in the hospital wanted to help out during this pandemic. And it was really very gratifying to see the response of all the hospital workers. It was a very challenging time to be an infectious disease doctor. Many patients were put on ventilators. Some of them survived, many of them didn't. Predominantly, these were older patients, but I saw some young patients get very sick, and some of these young patients actually passed away, sadly. But I have to say that we as healthcare workers recognize that we were not the only ones that were fighting this virus in this area. We were not the only ones who were sacrificing. We know that many of your businesses were declared as essential businesses and you stayed open and you struggled to keep your workers safe. And for that, we are very grateful. You provided us with food and other necessities of life, so we're very grateful. We also realized that many of your businesses had to close during this pandemic, and this was at tremendous cost to you and your workers, and you made sacrifices for the good of the state of Connecticut as well as the rest of us So we're really, I think I speak on behalf of all the healthcare workers at the Hospital Central Connecticut and MidState Medical Center, and probably everywhere in the state. We say thank you for all the sacrifices that businesses have made. We're very proud of what Connecticut has been able to accomplish in terms of control of this infection. In terms of any advice I might have for businesses, actively engage any of your sick workers to stay home. Some sort of daily health checks, symptoms and or temperature checks, very important. Encourage your workers to wear masks and socially distance. Limit access to places where your employees might congregate, such as the break room. Support telework policies wherever feasible. Increase physical space between your workers, and clean and disinfect frequently used areas frequently. And encourage what we call hand hygiene, which is washing and or sanitizing hands frequently. One of the biggest myths that I've noticed as a healthcare worker is that young people think they can't get sick. They're less likely to get the virus. However, I have seen patients who are young, who get very sick with the virus and actually have passed away from the virus. And also I would encourage young people to remember that they may not get very sick, but they can pass on the virus to their loved ones, elderly, people who have underlying medical conditions. And so I think everybody has to take care to wear masks and maintain social distancing. I'd also like to remind everybody in the community that hospitals are open, they are safe. I know that all hospital administrators have done their best to keep their hospitals safe, and we encourage people with medical problems to not be afraid to go to the emergency room. And I'd like to thank you again for the opportunity to be here.
Thank you, Dr. Bieluch. We really appreciate your presence today. And now we're going to hear from Dr. Lundbye from Waterbury Hospital. And I do want to add that we're so pleased that Dr. Lundbye has been chosen by our Healthcare Council as this year's Leadership Award recipient. And we're looking forward to honoring you, Doctor, on August 3rd through a virtual event that you'll hear more about at the end of this program. But without further ado, Dr. Justin Lundbye.
Thank you. Thank you, everyone. Just checking, sound check. Can you hear me okay? Great. Thank you, David. That's very good visualization there. So first of all, my name is Justin Lundbye. I'm the Chief Medical Officer at Waterbury Health. I'm a cardiologist by training, so not an infectious disease doc. However, I did my major in microbiology in college, so spent many days in the laboratory pipetting and plating and those types of things. The first thing I want to express is that this is a team effort. This is not a one individual person that has done any of this. So when I sit here, I really sit here on behalf of all of the healthcare providers in my community because it's incredibly humbling to see how we all came together to make a pandemic doable, and we were able to weather through the first part of it and all of it thus far. So with that said, let me just go over some of the stuff that we did as a team at Waterbury. Like Dr. Bieluch said, we started hearing about the infection and the pandemic back in December, and sometime in February, we saw more activity moving into the West Coast, specifically remember Washington getting hit pretty hard. And that's when I got concerned that we were going to run into trouble. So immediately I communicated to our leadership and asked that everybody start looking for PPE, specifically N95 masks. We also started looking for different drugs. At that point, it was more of a anecdotal experience from China that we sort of directed. So we looked at some antiretroviral drugs. We looked at the hydroxychloroquine drugs as a potential agent that we could stock up on. We also started thinking about ventilators because we had seen what had happened and we wanted to be prepared. And we did not have a big inventory of ventilators like most hospitals do. We started thinking about how we could manage these patients. I remember speaking to Dr. Porter, Paul Porter from St. Mary's back in February, and we were chatting about this, and we talked about the concept of creating a clean hospital and a dirty hospital, and somehow or infected hospital, I should say, and somehow trying to manage that and keeping the infected patients at one institution so we could continue to provide care for the rest of the community. Obviously, that did not come to fruition, but we thought about it and we discussed it and again, explored all options. Soon thereafter, back in March, we started seeing the infection coming into the state, and we knew we were minutes or days away from getting hit very hard by the infection. One of the caveats, and you may all remember this, but we were so struggled by getting tests. We could not get tests and test result in any rapid fashion. So we deployed all kinds of mechanisms to try to find ways and means to get testing. And the first thing we had to do was offer testing to our community in a safe way. And we knew that there had been some drive-through testing in different parts of the country. So we stood up the second DPH-approved testing drive-through center in the state of Connecticut, just after, I think, Norwalk was the first. So we were pretty proud of that. And then we started working with Quest Laboratory, LabCorp, Jackson Laboratory, and also internal processes to try to find means of testing rapidly. We had days when we went 7 days without having a result back on a patient, and it was quite frustrating. And I'm sure both Dr. Sims and Dr. Bieluch can sort of recognize and agree with the stress that we went under just to get our testing results back for our patients, so we could figure out if these patients were truly infectious. So we kept all of these patients in a PUI status, which is incredibly resource intense. Thereafter, we started visitation restriction, and we went to a very aggressive visitation restriction right away to protect our staff, to protect our patients, and protect our other families and that work or families of our workers. So it was a very calculated effort, but of course the community did not quite recognize that early on, that there may be difficult to get access to your loved ones. So we really had to do aggressive communication with that. We stood up 36 negative pressure rooms in a very short order, and we created a full floor that was designated to COVID patients. We created telehealth platforms for nursing to talk to our patients so they didn't have to go in and out of the room throughout the day. And it created a better means to get access to patients and patients to get access to their nurses in a very rapid manner. We also landed a telehealth platform for our patients in the community, outpatients, and did that in a very rapid order. Then came a very interesting period when we started to look at the prediction models, and I'm sure Dr. Bieluch and Dr. Sims remembers this, but we started studying what was our institution going to look like at peak. And we had numbers up to 300 patients coming in a day at one point that we thought maybe the calculation. It didn't turn out to be that, but that's what we prepared for. So we had bunk beds, we had all kinds of resources to try to prepare for all the patients that came into our hospital. The other part of this is the issue around taking care for patients in a safe manner was stopping and canceling our elective surgeries. And we had to do that. And part of the daily revenue stream for us is to have surgeries. And when you shut that down, it really hits your bottom line hard. But we knew we had to do that because it was the right thing for our patients. So in March, we canceled all elective surgeries and in fact, restricted who could have surgeries and when to a very limited number. We also set up a triage tent outside the hospital to make sure we had a place where patients could be evaluated without coming into our ED and potentially exposing everybody. Like I said, we expanded our pharmaceutical resources to look for hydroxychloroquine. Then we signed up with Mayo Clinic to become a research center for convalescent plasma, because we saw that there was some evidence that may improve our patients' outcome. We also started looking at remdesivir as a potential resource, and continue to work on that. And then, of course, looking at other stuff that we may be able to use to treat our patients. We also constantly, and we were really impressed with how well both the CDC and also the Department of Health communicated all the time. And the Connecticut Hospital Association were able to deliver communication very expeditiously to us, so we could make changes to our processes very proactively. And I got to tell you, and it's not just Waterbury Hospital, everywhere in Connecticut, how agile and effective we were of changing as a healthcare community from one process to another, literally in 24 hours, is quite impressive. And I talk about very complex and sometimes bureaucratic institutions that now had to really change their processes very quickly. And I got to tell you, it was very nice to see how quickly this came about. I'm going to wrap up by saying over the last several months, we have admitted over 280 patients with COVID into our organization. We have had multiple ICU patients, like Dr. Bieluch alluded to, some intubated for 30 or 40 or 50 or 60 days. And then we were able to extubate them, which, as we know, the prognosis of the intubated patients is not as good as those that are not intubated. We have tested tens of thousands of patients on both the inpatient and outpatient side. We have brought different testing platforms into our institutions to support our patients. We brought one in, ran out of cassettes. Then we brought another one in, ran out of cassettes. So I'm sure everybody recognizes the challenges of trying to find the testing platforms that we could use. We tested 1,600 of our own employed providers and staff, and had 2 positive COVID patients, which we actually knew about, out of the 1,600. We did a prevalence and incidence test on each and every staff member, the 1,600. I got to tell you, that's a little bit higher, it was 10%, but I suspect we had a very high false positive rate in our antibody testing. So I think it's less than that, but needless to say, our active PCR was quite low. So moving forward, we restarted elective surgery. We did that by testing our surgeons on a weekly basis. If we didn't like the surgeon, I would test it a couple of times in the nasal cavity just to make sure I got back at them for whatever they did to me. And if they were very nice, I would do an oral swab or an oral pharyngeal swab, which we can also do. So it depends on who I was working with. We started to tee it up very slowly and get the right surgeries in first, and then when we saw it was safe, we continued to expand it, and now we do everybody. I got to say, today we're very close back to normal operations. Our census continues to be somewhat low. Our COVID patients are no more than 1 patient at a time, and a lot of it's interesting. We're seeing these patients that were tested positive back in April or May coming in with a different condition, but because we test everybody that comes through our hospital doors into the ED that get admitted, we sometimes pick up some of that viral RNA, and because they're showing up as positive, we put them into a POI status until we figure it out, even though we think it's all just fragments of old virus that no longer lives, as I'm sure Dr. Sims and Bieluch can agree to. So moving forward, we're going to continue to stay very agile and be prepared if something is to change. We have a lot of safeguards in place. I got to tell you, we never ran out of PPE. We were able to provide PPE to all of our staff every day. And that's something that we're very proud of. And we're already stockpiled a set in case we have a second round of all of this. I'm hoping our epidemiologists are going to say, no, it's not going to happen, Dr. Lundbye, but who knows? And then lastly, like Dr. Bieluch, I want to thank everybody, the whole city of Waterbury, the whole, really the whole state, CHA, the local Department of Health, the State Department of Health, all the businesses that came forward and came up with creative ideas, the way they could help us, either by feeding me a lot of food, which is very important. I'm being a little facetious, but I enjoyed it. But also bringing in technology that could help us. They retooled their process, their factories, to bring us different processes that we could use in caring for our patients. I'm really humbled on all the good work that our EMS folks do, and our fire departments and our police departments. It's really been a team effort, and it's very nice to see how we all came together. Thank you for listening to me for this long. I appreciate it.
Thank you, Dr. Lundbye. And now we're going to hear from Dr. Michael Sims from St. Mary's Hospital.
All right, good afternoon. So my name is Dr. Michael Sims. I've been here at St. Mary's Hospital since 1984, Director of Infectious Disease and Infection Prevention. I would reinforce everything that's already been said so far. I won't go back over all of that. We have had a very, very similar experience and have dealt with it in a very similar way. My career and Dr. Virginia's career has been very similar, starting our careers with the pandemic of AIDS when we started as infectious disease physicians, and then going through the various epidemics and pandemics. But one we haven't talked about that always is in the minds of infectious disease physicians that also reflected our current experience was the great influenza of 1918. Now, as infectious disease physicians, we've known for decades that another great pandemic was coming. And many of the infectious disease physicians, including Dr. Fauci himself, have predicted that it could likely be a coronavirus, which is in fact what this one ended up being. And we knew that based on the experience of the great influenza in 1918, 1919, it would be something that would literally change the history of mankind. It would kill millions of people. The US death rate in that influenza outbreak was over 500,000 people. And similarly, there was no treatment in those days for influenza. There was no vaccine for influenza. So the experience was very similar to what infectious disease physicians knew we would go through if we ever were hit with another pandemic. And each time SARS or MERS or swine flu or bird flu came along, there was always a question of whether this was it. This was the new great pandemic that we were going to have to deal with. And now it's here, and it happens to be a coronavirus. And it is wreaking the same type of havoc that the great influenza did in 1918, 1919. I'd like to reflect back a little bit on the future as well, which is with all the great things that have happened to date, and I again would reiterate the tremendous cooperation and professionalism that's been shown by everyone, but also the great sacrifice, and particularly the bedside people. People may not be aware of the fact, but just in the last few days, there was a memorial at the Capitol. They put 154 pairs of nurses' shoes on the front lawn. They represent the 154 nurses to date that have lost their lives to coronavirus. This reinforces the fact that whereas we all signed up, knowing that we would have to sometimes put our lives on the line, particularly nurses, nurses' aides, respiratory techs in this case, who had to be at the bedside. Nobody signed up to do it without adequate PPE and with adequate tests. And we're all very proud of our medical leadership and our political leadership locally on the state level. We have to acknowledge that the federal leadership politically has been a disaster. They have really let the country down. They have asked nurses and nurse aid, respiratory techs, physicians, EMTs, people on the front line to do their job, scrounging around for tests and scrounging around for PPE, and that still goes on today. Other countries, New Zealand, Greece, Singapore, Hong Kong, Taiwan, have solved this problem and have had adequate facilities and resources for their healthcare workers. So whereas I'm very proud of the professionalism that's been shown by everyone and the cooperation of all through society in bringing this pandemic to heal, and it's not over yet, we have to acknowledge the fact that the healthcare system and the community and the society including the impact it's had on the economy, has been asked to deal with this without adequate resources or leadership at the federal level, politically. The other thing it's important to realize is not gone yet.
Bye-bye.
I find now that it seems to be a tendency for people to think that Connecticut has gotten through this and it's over and it's time to get back to life as normal. Life will not be normal for a long time. We're going to have to learn to live with this virus. So we need to acknowledge that as a healthcare system, but society needs to acknowledge we need to find a way to run our businesses, open our schools, congregate, socialize, and live life in the presence of this virus. Hopefully one day we'll be able to do that in the presence of a good vaccine and adequate therapy. And when we keep the numbers down, we'll be able to deal with it. It won't be an overwhelming number of patients as we've seen in the previous months. But it's important to acknowledge that this virus is here to stay, and we're going to have to learn to accommodate ourselves to that. It's also important, it seems to be a bit of a laissez-faire attitude, particularly by the young people. This is a terrible disease. All you have to do is spend some time in the hospital and see how people die. You essentially suffocate to death, and you do it alone because people are not allowed in the room, not your family, not clergy. You will have perhaps a nurse who is dressed with PPE from head to toe, holding your hand through a gloved hand. And when you die, if there's no room for you in a funeral home or a morgue, you'll be put in a refrigerator truck. You won't get a funeral, you won't get a wake, and then you'll be buried or cremated. So if people think that it's over, it's not that bad, and they can go about doing what they want to do, I think it's important to understand that the difference between Connecticut and Florida or Texas or South Carolina is society taking this seriously and following all the guidelines that Dr. Virginia outlined for us. It's important that people continue to take this seriously and not underestimate just how bad a disease this still is and the fact that it's not going away. Thank you.
Thank you, Dr. Sims. And now I'm going to turn our program over to our Director of Public Policy and Economic Development of the Waterbury Regional Chamber, Dave Kraszewski, who is going to moderate questions that have been submitted from our audience today. Dave?
Thank you, Lynn. So now we'll do our Q&A. We did have several questions submitted in advance, and we also came up with a few of our own, and we'll start with those. But if you have a question that you'd like to ask, feel free to put it in the chat. It's part of the feature of Zoom. If you go down to the bottom of the screen, there's a little button that says chat, and you can type in your question, and we'll try to bring in some of those questions as well. So for the first question, and this can be answered by any of the three doctors that are with us, we thought we'd start with maybe the basics, and that is really how the COVID-19 coronavirus is different from or similar to the flu and other coronaviruses. Who wants to take a stab at that?
Well, I'll start. The flu and the coronaviruses are different families of viruses, and so they're going to have different structures. And along with that different structure is going to be a different way of attaching to human cells and causing illness. There are, as many of you might know, there actually are 4 coronaviruses that have circulated widely before COVID-19, and they tend to cause mild respiratory illness. There's other respiratory viruses such as RSV and rhinovirus that can cause respiratory illnesses, but they all behave slightly differently. And I think everybody in the world has seen a picture of the coronavirus with its spike proteins. The coronavirus gets its name from these spike proteins, and these spike proteins attach to cells in the respiratory tract, predominantly the nose and the lungs, and thereby go on to destroy cells and cause inflammation. So the mechanism, although the respiratory tract is involved with all these viruses, the mechanism of causing disease is slightly different. I don't know, Mike or Justin, if you have anything to add?
Yeah, I think it's important because we've talked about the flu and coronavirus in the same sentence, and this is something I see people commonly have a misconception about. I've heard people say, well, this is really no worse than the flu. Why are we getting all in a lather about this? And I think it's important to understand the differences. Well, the flu is bad and kills 40 to 80,000 people a winter, which is bad enough. Realize that at least with the flu, we have a vaccine, we have treatment. Some people are immune to it. If they've been exposed to flu before, there's some partial immunity there. Generally affects about half the planet at a time. So it'll be in the winter in the northern hemisphere and then switch over to the winter in the southern hemisphere. And the coronavirus we're dealing with now, no one has immunity to it. We have no vaccine. We have no effective treatment. The entire planet is susceptible to this. It's more infectious than the flu, and it's already killed more people in 6 months than the flu will usually kill in a year. So it's important, I think, for people to understand, whereas they are both respiratory viruses and the flu is bad. I don't want people to underestimate how bad it is. Say, well, I don't need a flu shot now. After all, I got through corona. That's a lot worse. But understand that this is a worse virus. This is much more worrisome to us as infectious disease specialists than the flu is. And again, people should not take this lightly and assume this is just another respiratory virus like the flu. I made it through flu season and I'm good to go. I can take my mask off and go to Costco.
Yeah, the only thing I would add is it may be more practical to compare this virus to the other coronaviruses that have sort of been around. Back in 2002, there was a SARS COVID outbreak in Guangdong, China, and had the same mechanism. It attaches to the ACE receptors and goes through the same process, but it was a less virulent infection. And what do I mean by that? I mean that the ability for the virus to infect, it appears at least, was less than what we were seeing with this infection, which is much more aggressive. In other words, it doesn't take a lot of viral particles for it to get into the host and cause its damage. And I think we're seeing that. And that was one of my early concerns about this infection, is that it had an incredible ability to jump from person to person. And we saw that with how quickly people got exposed in the community and also early in the healthcare settings.
I think that's a really good point. The first SARS virus, the outbreak was actually controlled after a couple years, and one of the differences is that that particular virus is more likely to spread person to person after you get symptoms. And although it is more lethal than the current SARS virus, it was easier to control because when the patients were identified, they could be isolated and thus prevent person-to-person spread. This virus spread, the scary thing about this virus is it spreads even in the absence of symptoms or before you have symptoms. And so it's just highly contagious for when you don't even know that you're sick. And that's what's really scary about it.
We actually have a follow-up question that is sort of in that same vein. We have someone asking, if you've had the virus but have since recovered, can you still spread it to others?
Well, we know that there's a certain period of time after you become symptomatic where you will shed virus. And as Dr. Virginia has pointed out, you do start shedding virus before you become symptomatic, which makes it very difficult to control spread, which is why it's important that everyone wear masks and not congregate, even when you're feeling well, and even when the other person is not ill. It appears that most people stop shedding virus about a week after you become ill. In the case of some immunocompromised patients, it could be longer, as long as 10 days. And for severely immunocompromised patients, they recommend that we continue to surveil those patients, see if they're still shedding virus. So it does appear that you continue to shed virus, but only for a period of maybe a week to 10 days after you become ill.
And you know, the irony here is that, like I alluded to earlier, you'll have patients that come in 60 days after their infection for a completely different symptomatic presentation for something else. Maybe they're having, you know, a broken leg or something, and we'll test them and they'll be positive. And we think that's just viral fragments that really do not have any, you know, infectious properties or anything like that.
Okay, thank you. So what is the most typical way for a person to become infected with the virus?
The predominant mode of spread of this coronavirus is by droplets, and droplets are larger particles that we expel when we talk, sneeze, cough, etc. And they're believed to travel up to 6 feet. There's a minor mode of spread is thought to be from a contaminated surface, such as a doorknob that lots of people handle, and one person has coronavirus on their hand, touches the doorknob, the next person touches the doorknob and touches his or her face, which is another way. And then there's there's some concern that maybe there is some spread via what we call the airborne route. And airborne particles are smaller particles that are sort of suspended in the air for maybe a longer period of time, a few hours. And so there's some thought that maybe there's some airborne spread, and that's got to do with congregate settings where a lot of people were together, churches where people sang and a lot of choir members got infected. But the predominant mode is droplet spread. And again, I'm going to say what Dr. Sims has been saying: wear your mask. Okay, if you're asymptomatic and you talk or sneeze or cough, wear your mask, because that will prevent these droplets from going to other people.
And related to that, I'm just going to piggyback on what Dr. Sims and Bieluch said. When people wear masks, the protection of yourself, the person that's wearing the mask, is really not what we're after. It's protecting the people that may be exposed to the aerosolization that occurs from the person that's not wearing that mask. So when I wear a mask, all I'm doing more or less is preventing my potential infectious disease to go to someone else. And it's pretty dramatic how much of a difference that makes than compared to those that don't wear a mask.
There's a case report from another state, and there were 2 hairdressers. One gave the other one COVID when they weren't wearing masks, and they styled hair on 139 people, everybody wearing a mask, and none of their clients got infected. So I'm not telling you to go out and work when you've got COVID, but I think there's more and more data now about how important masks are to preventing droplet spread.
Okay. I do have a related question for that as well. Someone asked, you go out in public and you see people who aren't wearing their mask correctly. Their mouth might be covered, but their nose might be out of the mask. The question is, the way it was put to me was, since the primary vehicle for aerosolization is the mouth, is wearing a mask with the nose uncovered still mostly effective? And I'm not sure that the science of that is correct, but I'll leave that to you to let me know.
I'm going to step out on a limb and say that it hasn't been well explored, but the purpose of it is that you get air out both your mouth and your nose. You're going to expose people either way, so you want to cover up both orifices.
The predominant receptors that the virus likes to go to stick to is in the nose. And you'll have many more viruses in your nose than you will in your mouth. And so there's a lot of these, what Dr. Lundbye calls ACE receptors, and they're in your nose, and you just have a lot of viral particles. So any air that you expel or if you sneeze will have a lot of viral particles in it. So yes, it's really important to cover your nose with your mask.
Okay. We do have a couple of questions relating to the fact that some people seem to get a very mild case of the virus when they contract it. And so there's 2 related questions. One is, if any of you know the percentage of the people who require medical treatment or hospitalization as opposed to those who don't. And then the second part is there any chance that this virus is weakening in any way at this point?
Yeah, the statistics are out there nationally based on how many people get severely ill, how many get hospitalized, how many die. It seems to be about, 80, 15, 5, etc. But understand that that really also depends on the group. So one should not take solace in the fact that, oh, I've got an 80% chance of doing fine. If you happen to be a middle-aged, morbidly obese male with poorly controlled diabetes and hypertension, you're not likely being at 80%. The other thing to remember is we've already talked a lot about the fact that this can be spread by asymptomatic people, pre-symptomatic people, people who aren't that sick. It's interesting, there have been signs with nurses, saying, I came to work for you, please stay home for me. I would add to that, wear your mask for me. Understand, yeah, you may be a robust, healthy 25-year-old, and maybe you're gonna be at 80%, but maybe your parents won't, your grandparents won't, your spouse who's on steroids maybe won't. So understand you have a responsibility not only to yourself, but to everybody you're in contact with. And you shouldn't bet on the fact that because 80% of people may do okay, not get hospitalized, that guarantees that you will, because we've had 20-year-olds die. And it also does not mean the people you're in contact with are going to do that well. They may be in that 15 or even 5%. So everyone has a responsibility to wear their mask, including over their nose, and minimize the chance of spreading virus and not rely on the fact that statistically, 80% of patients may have a mild infection or not be hospitalized.
And unfortunately, as Dr. Sims alluded to, at this point, it's really impossible to predict who's going to get really sick with the virus. And we just don't know enough about it. I have seen elderly people who don't get sick, and I've seen elderly people who die. I've seen younger people who get put on ventilators and who die. And we really don't know the reasons why some people do less well than others. And so you can't bank on the fact that you're 25 years old.
Okay, so is there a particular mask that is best? Because we've seen all kinds of options, everything from people wearing simple cloth masks to the N95 mask. And is it important for people to what mask they're wearing?
Well, it is depending on your exposure. So I think at the very minimum, everybody should be wearing cloth masks in the community. When you get into very high risk exposures, like in the hospitals, then we're using surgical masks that also have an electrostatic charge that takes some of the virus out. And then in the case of situations where the virus can be aerosolized, as Dr. Virginia pointed out, there are situations where medical procedures or other situation where people aerosolize virus, then using an N95. But understand that N95s are uncomfortable to wear for a long period of time. So you wear them at time of greatest risk, but it would really be very burdensome for somebody in the community to wear that all the time, which is what we want people to do. So in that case, a cloth mask to control the droplets, which has already been discussed, is fine. If you are in a medical situation, then you should be wearing appropriate covering, including surgical masks, N95s, and we even use N95s covered by surgical masks in order to keep the N95s clean so they can be reused and not have to be disposed of early. The important thing is, whatever mask you choose, wear it, including over your nose.
I want to add one more point to this, which I think is important, and it's just really for the public to understand. And the numbers that I'm giving are not as important as the contrast. If you have two people in a room, one is COVID positive and one is COVID negative, and the COVID negative person, meaning they don't have the infection, wears a mask, but the COVID positive with active infection does not, the probability of the COVID negative wearing the mask getting the infection can be as high as 70%, because especially depending on time duration and how close and so forth. So again, the number is not as important as the concept here. if the COVID positive is wearing the mask and the person that is not COVID positive is not wearing a mask, that risk of infection and transmitting it goes down to a single digit. Again, numbers are not as important as the concept of the message of wearing the mask is really to protecting the people around you. It's not to protect yourself. If both people wear a mask, contagious and the non-COVID positive patient, you're talking about close to a 2% risk of spreading that. And that's why we all wear masks in the hospital. Our risk of getting exposed by a COVID positive really goes down, even if it's just a surgical mask. And especially if you're putting that mask on a patient during transport and so forth. N95 is great, to Dr. Sims' point, when you're going in and you're going to be in close contact with a patient that you know has COVID-19 and you need to protect yourself because you have to be close to them to do therapy on them.
The other point about an N95 mask is, in order for it to work properly, has to be what we call fit tested. And we all get fit tested once a year. If you gain weight, lose weight, have a beard, etc., you may not be able to wear an N95 mask and have it do any good. So again, just a cloth face covering. And there's been another study out of Boston where they had some transmission in the hospital. And so they had everybody start to wear masks, and they saw their transmission in healthcare workers go way down steadily as people wore masks. So it's well demonstrated that a mask helps.
Okay. Another question we have submitted, I'm sure we're all aware of this by now, is there's talk of having children going back to school in the fall. And the person submitting the question just would like to know what your opinions are on that, and what practices should the school take to best protect their faculty and students?
Well, I think, we'd all like to see children go back to school. And I think there are certain criteria the CDC has laid out for schools to even consider reopening. I understand the anxiety on the part of parents. I understand the anxiety on the part of teachers. I have a daughter who teaches in another state, and there's a lot of anxiety. I think whether or not children can successfully go back to school is in the hands of all of us. If we can keep this virus controlled by wearing masks and socially distancing and decreasing spread in the state of Connecticut, I am hopeful that with the measures outlined by the CDC, that children can at least start to go back safely. I think there are parts of the country that maybe should reconsider opening schools at this point in time. But again, in Connecticut, we've done a great job, and it's up to all of us to keep the numbers down and to see if we can safely get children back to school. Masks, social distancing, all the things that the CDC has laid out for schools. So, I think school is important. Socially, children just need to get back to being children to the extent possible. But again, if the numbers start to go up, the state of Connecticut may need to rethink having kids go back in person to school.
I want to echo what Dr. Bieluch said. I agree 100%. Right now in the state of Connecticut, based on the numbers that we're seeing, we're doing the right stuff, and we got to continue with that, even do a little bit better. Then, yeah, I think we can contemplate with safeguards putting our students back in school. I know my wife certainly wants to see kids go back to school. So, it really depends. If we start seeing an upshift again, then we may have to pump the brakes and think of plan B.
I think it's an important point relative to this and other things, which is you can't negotiate with the virus. It tends to be this feeling like, well, we've been through it and the masks are hot and sending the kids back to school is a problem. Just send them back to school because that'll be easier. I think you need to realize that you need to follow the rules. As Dr. Fauci often will say, people ask him a question, he'll say, the virus will tell us that. The virus will tell us when it's safe. The virus will tell us what we can do. So it's important that we be very realistic about this and we keep the numbers low, and we have to get back to living, including letting the kids back to school, but we remain sensitive to the fact that the virus will dictate ultimately what we're allowed to do. And if we can maintain those precautions we have to keep the numbers down, we can get back to some semblance of normalcy again, including letting the kids go back to school. But if we begin to get laissez-faire about this, everyone's going to suffer, including the school kids. We're going to have to shut the school down and maybe start to close down society again. So it's important that we listen to the virus and that we listen to the epidemiologists and we listen to the experts and we do it safely.
Well, do we have a better handle yet on how or whether children infect their parents or parents infect their children? And, you know, I've heard differences among age groups and things like that. Do we have a better handle on how that infection occurs between those two cohorts?
I think there are, first of all, children of any age can get infected. Children have died of this infection, predominantly children who have underlying medical conditions. But they are less likely to become ill. I've heard that there's some data that once they get to be the age of 10 or so, they transmit virus just the way us older folks do. So that yes, if they acquire the virus in school, they can bring it home and they can give it to their teachers. And teachers are understandably concerned, especially if they're older and have underlying health conditions. But yet, children can certainly transmit the virus. And they're more likely to be asymptomatic. So, we know the virus is spread very readily from people who are asymptomatic.
Okay. We're sort of getting close to time here, so I did want to ask this question. It may be the big one, which is, when should we realistically expect a vaccine?
Yeah, well, it's a big one. I don't think anybody, even Dr. Fauci, who we all love and admire, can tell us that. You've all heard about Operation Warp Speed, where the government is putting out unbelievable amounts of money and paying the vaccine manufacturers to ramp up production of vaccines that we don't even know whether they will work. But if they do work, we'll have doses ready to at least start deploying. I've never seen anything work this fast, and I know that there are safety concerns and people are concerned about, yes, we're going to hurry up and make this vaccine, but is it safe? And I think people are going to do the best they can, but sometimes it's only after a vaccine has been out that you actually get all the safety data. The last phase of trials, phase 3 trials, are going to be underway. There are some promising results from a vaccine from this country, as well as one from the United Kingdom. You know, honestly, I don't think it will be before the beginning of next year at the earliest, but, you know, I could be wrong, and I hope I'm wrong. Mike or Justin?
Yeah, it's interesting that on the one hand, this is being developed at an unprecedented speed. Normally it takes decades to bring a new vaccine to market. And so the fact that this is being done in a period of months, realize they only sequenced the genome basically like 7 months ago. And now they're already starting to do human trials and talking about making the vaccine available early next year. If that's true, that this will be a historic accomplishment on the part of the vaccinologists and the virologists. But on the other hand, we still have 1,000 people dying every day, so it can't come soon enough. But understand that whereas this is unprecedentedly fast, it's still very slow in a setting where society's locked down, the economy's been destroyed, the kids can't go back to school, you have to wear a mask, it can't come soon enough. But understand that it's being brought to the market. And again, realize we're going to have to immunize 7 billion people. And they're now talking about it may take 2 vaccinations per person. That's 14 billion vaccinations. That's never been done before. So this is historic, but again, it can't come fast enough. It needs to come quickly and it needs to be safe, but it's frustratingly slow when you're living through it every day.
Okay, we still have a little bit of time. I do have some business-related questions that I'd like to try to get to, at least a couple of them. And one really has to do with if you have an employee who is tested positive and what the recommendation is for getting them tested or quarantining them or, you know, allowing them back to work, especially given now that I'm hearing that it can take 7 to 10 days to get a test result back. So what are your recommendations for businesses that are dealing with a worker, a staff member who may be facing the virus?
I say the easy answer is wear a mask. There's been a lot of discussion about when do people stop shedding virus, if they're exposed, how long should they stay out? What about antibody levels, which are pretty lousy to start with? How often do you test someone? And the answer is if everyone's wearing a mask, then it makes the risk a lot lower. We permit people to continue to work with a mask as long as they don't take care of immunocompromised patients. That's the CDC recommendation. Obviously, if they become ill, it'd be wise to have them quarantine themselves. But I think all those different scenarios of, do I have virus, for how long, who else has virus, can I work, how long should I stay home? A lot of that is mitigated if everyone's wearing a mask. And then if you have people at high risk, either because of underlying illness or they're ill, then obviously you take extra precaution, you quarantine them, etc. But a lot of that angst can be relieved if everyone's wearing a mask.
I think if someone has a COVID-19 illness, the CDC recommends they be isolated for up to 10 days. Even though your test can be positive after 10 days, actually culturing a live virus is extremely rare unless you are an immunocompromised patient. So for the majority of people, we consider them infectious for 10 days after the onset of their illness and resolution of fever for at least 24 hours without taking anything for fever. So I think as long as they're getting better, probably 10 days they should be out. If someone has no symptoms and has had an exposure and is tested positive, then the recommendation is that they should take precautions and isolate up for 10 days after their positive test. And in this scenario where you're waiting for a test, if the patient is symptomatic, you probably don't want them coming to work until they either have a negative test and you're sure they don't have COVID or they've passed the 10-day isolation period. It is really unfortunate that people are waiting so long to get test results back these days. This has been an issue, as Dr. Lundbye says, back since February, where we had very limited testing. We could only test certain people. And it is, I understand, taking up to 7 days to get a test result back. So if you don't know, I think you have to consider the person potentially infectious. I think a lot of the testing, to my understanding, has been diverted to other areas of the country where they have a lot of active cases of COVID. And so, I'm hopeful that the business community can find ways to really be understanding in terms of people who are staying out of work, either because they've got COVID or because they're waiting for tests or they have a positive test. Because I do think, yes, we should all be wearing masks, but I think there are times when employees just probably shouldn't be at work.
I echo what everybody else said. The only thing I would add is that the CDC sort of adds a couple of different pathways where you can triage your staff when they should come back to work. One is symptomatic monitoring, 10 days after, fever resolution and no symptoms with any antipyretics or anything like that. Or you can do a testing strategy. But that, again, has the caveat of now all the testing volume has ramped up everywhere else. So we're going to be, on the wait list to get the results back. And then, of course, you have those patients that just carry these fragments in their oral or nasal pharynx for a long period of time. And we don't know why that is, but we just, it happens. So that's going to be a difficult one to determine. So probably the symptomatic and monitoring process is the easiest way to do it.
I think the CDC currently thinks that the symptomatic, following symptoms, 10 days after symptoms, fever resolution is the way to go.
Yeah.
Because one, we don't want to clog up testing, and two, people can have positive tests for a long time. But when you try to grow the virus in the laboratory in an otherwise healthy person, they can't grow it after 10 days. So we have been very comfortable here in the hospital using the symptom-based return to work policy.
Okay.
The caveat that we're faced with that, David, I'm sorry, but this is an interesting concept because nursing homes wants us to send back patients with 2 negative tests. Mm-hmm. And if you follow that process, sometimes we're stuck with patients that are asymptomatic for a long period of time.
Right, because you may get one positive test in there before you can send them back. Yeah. So, what should we be looking for to know when it's safe to get back together, start socializing, open restaurants a little bit more, open businesses a little bit more? The virus obviously isn't going to disappear, but what signs is it just that the distribution of the vaccine, or is there something else that we can look for that'll tell us that things are really improving?
Well, hopefully, when we have the vaccine, then similar to the flu, the majority of people will be immune. And then hopefully we'll be able to get to a kind of a more normal control of infectious diseases. Realize that we don't normally control infections like this. In the case of tuberculosis, the flu, etc., we identify who has it and quarantine them and let everyone else go about their business. The fact that we have inadequate testing and inadequate PPE and no vaccination and no treatment is why we've had to take such a radical approach to control this thing. The hope in the future would be this will become one more pathogen that we have to deal with, and we'll be able to identify, once we have adequate testing, who is positive, who needs to be quarantined, who needs to be wearing a mask, who needs to be treated, who needs to be vaccinated, and then we'll be able to get back to a little bit more of a normal existence like we do with the flu and tuberculosis and other contagious infectious diseases.
Again, I think we should be very proud of what everybody in the state of Connecticut did. Everybody took this seriously. Businesses did what they were asked to do. And I think the real concern right now is twofold. One is people coming in from the other states that have rampant virus. And, I know we have seen people who have traveled, who have come back with COVID. And so there's always going to be people coming in. And I think that's one of the governor's concerns about reopening is this could, our numbers could start to climb any day now, and that's scary. But I also think, again, it's in our hands, and if people wear masks and socially distance, I think things will stay the way they are as long as people don't bring in the virus from other parts of the country. And the other thing is, it's a little scary for me. I don't know what's going to happen in the fall. When people start to be inside more, right now people's extracurricular activities are outdoors, but when they start going to bowling alleys and and more movie theaters because it's getting cold, whether or not we'll see an uptick in virus during that period of time. I know some towns are allowing outdoor dining until October, but it's going to get a little chilly out there at night once it gets to be October. So my hope is that the numbers stay down in Connecticut. I think a lot of it is up to us, and I'm hoping that restaurants and things can not reopen, but we can have a few more people inside if everybody does what they're supposed to do and the numbers stay low. But I don't have a crystal ball. And I think we need to keep a really close eye on the numbers, and when things start to tick up, close down again. I know it's a big sacrifice on the part of everybody, and we really do appreciate it because this really has taken an entire community to fight, not just the healthcare workers, but an entire community.
Thank you, Doctor. And thank you, Dave Kaszewski, for leading our Q&A and the expert panelists that we had this afternoon on today. And thank you to all the members that are here. We are going to continue the conversation about viruses and vaccinations. And we're going to have on August 3rd from 8:30 a.m. to 10 a.m. during our Healthcare Council annual meeting and awards, a keynote speaker who is renowned in the topic of viruses and vaccines, and that is Dr. Peter Hotez of Baylor University in Texas. He is an internationally respected expert, and we're so pleased to be able to bring him here to our chamber, to our members, and you can register on waterburychamber.com. We look forward to seeing you then, and always, please keep in touch with us. Check out our website for information that is updated daily on COVID and other business resources, and that's waterburychamber.com. Thank you all for attending and have a great afternoon.